Laparoscopic left partial nephrectomy for a completely endophytic tumor. In the absence of intraoperative USG guidance, how did we navigate? A 39-year young male presented in OPD with complaint of pain abdomen and incidentally detected left lower pole renal mass. He had no comorbidities. Per abdomen and systemic examination was unremarkable. In preoperative workup, CCT abdo and chest revealed a well-defined enhancing solid mass 2.8 by 3 by 2.8 cm in lower pole of left kidney involving cortex and extending into medulla with no perinephric extension. Renal vein showed no thrombus. Renal score was 9x. There were no evidence of lung metastasis. Routine blood investigations were unremarkable. This is a CT urogram showing a lower polar endophytic tumor compressing the inferior calyx. The same can be appreciated on a coronal image. This is an arterial scan showing a lower polar vessel supplying the tumor. Standard 3 ports as we use in a left nephrectomy were placed. After left colon mobilization, hilar dissection was done. A single artery and a single vein were identified and looped. Tumor marking was done, corroborating the CT findings. Intrahilar dissection of the lower polar vessels as identified on a CT was done. They were separately ligated and cut. After this, the main renal artery was clamped and tumor resection was started. Care was taken not to enter into the tumor. During tumor resection, an intermittent saline irrigation from the assistant port helped in delineating the peritumoral plane. Medially, the plane of resection was just adjacent to the ligated ends of lower polar vessel. This helped us in clearly delineating the plane of enucleoresection. After cutting through the lower polar collecting system, the rest of the tumor was resected from the renal parenchyma. PCS closure was done using a Vicryl 4O in a continuous manner. Inner rhinography was done using a V-lock 3O suture. Outer rhinography was done using a 2O V-lock suture in a continuous manner. A plate made of Surgicel and Abgel was placed during outer rhinography to ensure a better hemostasis. At the end, main renal artery was declamped and the fossa was checked for any bleeding. The specimen was bagged and retrieved through one of the port site incision. Intraoperative details. Total warm ischemia time was 38 minutes. Total duration of surgery was 150 minutes. Total blood loss was around 100 ml. Post-operative course was uneventful and patient was discharged on POD5. Histopathology revealed clear cell RCC, stage PT1A. At follow-up of 3 months, patient is asymptomatic with no evidence of tumor recurrence on CECT abdomen with a serum creatinine of 1.04. So to conclude, for a completely endophytic tumor, intraoperative USG is must to identify and delineate the plane of resection. However, in the absence of it, a detailed CT review on console can help identify the vessels supplying directly the tumor and also the best plane of enuclear resection. Thank you.